basic scientists, you have great clinicians, so it is a true pleasure to be part of what you're doing here. So I hope you don't expect too much, because the title is very promising, but the science and the clinical knowledge behind the topic of sleep injuries and violence is not that large, is not that deep, and I will try to give you an overview of what we know, and you will see what we do not know. It is, however, obvious that this is a very important topic that has been neglected, not only because what happens in sleep happens during darkness, but also because there are probably some misconceptions and also some prejudices. So the goal of my talk is really to present to you a topic that I am certain, and I know, will occupy your clinical and maybe also your scientific career more in the future than it has been in the past. The next one, please. I don't know how to move on. Can I just choose? It's not really enough.
Можно, Николай, можно в следующий слайд?
So, when you talk about sleep and violence, we usually present this small phrase or extract from the book of Miguel de Cervantes, Don Quixote. I will not read it, but this is a scene out of sleep, and actually this is probably, as we believe today, a first good clinical description of REM sleep behavior disorder. It reminds me that many descriptions of clinical syndrome have been done in a very precise way by artists. So whenever somebody from a non-scientific domain tells me about some observation, I always listen, because sometimes including artists are better observers than very concentrated and focused scientists. Please, the next one.
Следующий слайд.
So I would like to structure my presentation in three main topics. First, what is the problem we're talking about? How frequent, how severe, how does it present? Then, if we talk about some people, some patients that get injured or get violent during sleep, what are the causes that we, and imagine most of you are clinicians, which are the causes that one should consider? So what is the potential etiology? And finally, how do we address the question? And you know, one of the difficulties when we talk about sleep injury and sleep violence is that these are episodes, not something that is continuously present like a physiological, pathophysiological variable. And so usually we have to reconstruct retrospectively what happened, and we do not have a really proof of what, you know, a documentation of what happened. So it's a kind of a reconstruction which has its limitation, but as you will see, it has its importance because there are some forensic cases that you may be aware of that then needs to be addressed and solved. The next one. So let's talk about the problem. And as I mentioned, the next one, please.
Следующий.
Next. So let me start with two cases, two well-known cases, and I will not give you the solution, and try to think what you would say if you have to give a judgment on the case. The first case is this young man. It's a case that I was not involved with, but it's a case that has been published, and it happened in May 1987. This is a young man who actually did not have much, I'm sorry, yes, no, this is correct. So he did not have much sleep the night before the episode that occurred during sleep. So he had a sleep deprivation preceding the night where the episode appeared. And I was just wondering, because the history is somewhat similar to the next one, you will see. And the story that was reconstructed is as such that at 8:30 at night, he puts his baby to bed, and then, this is maybe not surprising for somebody in the United States, unfortunately probably it's in Russia, he spent much time looking at the TV, today maybe the tablet, with his wife. And then eventually the wife went to bed, and he then fell asleep on the couch at around 1:30. The story is that everything that happened later had to be reconstructed. So this is what then was rebuilt, so to say. And what the story is that he got up out of the couch, went to his car, and drove to his parents-in-law. This is a distance of about 10 to 15 minutes by car. So he had a very vague remembering of what happened. He entered the apartment of his parents-in-law and actually strangled his father-in-law and stabs his mother-in-law, and both were killed. They were in a small room, so they were not in different rooms of this apartment. I should say, I cannot go into all details, you can read them, I will show you the reference, that he had a very good relationship with his parents-in-law. So this was not related to some animosities or any problems between this man and his parents. He woke up after the event and had actually basically no recall of what happened. So he had his the knife still in his hand, the blood on his hands, and he actually himself was shocked, went to the police, he kind of regained consciousness, and he said, I think I have killed some people. So this is the story, and one should ask himself, if you are working in the field of sleep, so how do I work up this person? How do I work up this situation? Knowing that you were not there, as I mentioned, the documentation is not there. So do you believe? What could be the explanation? How do you work up this patient? Let me show a second case. Next one, sleduši. So this is a patient that I have seen. We do not have a picture. You will understand why. This is a picture that it was a famous case in Switzerland. I had to make an expertise, and the patient was then, the picture was drawn during the forensic debate that took place after what happened. Now, please note, this is an episode that appeared the night before Christmas, which has kind of a twist in the story, as you will see. She had a good sleep the night before the episode, and that's why I was wondering, because the story is a little bit a similar story. It's about the family. She's a young woman. She puts her 2 children to bed and watches TV with the husband. So believe me, this is really the story, because I was wondering if I messed up the picture. So it was, the beginning was the same. She then gets up twice. This is what also the husband could refer. And she got up once because she had, again, some tension headache. She had to take a painkiller. And then she put the presents under the Christmas tree. At 2:15 a.m. in the morning, she opens the door and wakes up the husband. So she wakes up the husband, and she said, look, I found our 2 children dead in the bed, and they had a pillow on the face. So how do you approach this story? What do you think happened? Okay, sleduši. I will come back to these 2 cases at the end and present what the explanation has been. So now, talking about the problem, let's look at what the literature tells us. And you don't find that much literature. This is probably one of the largest series on sleep-related injury. As you noticed in my title, I speak about violence and injury. It's not exactly the same. Now, about injury, this is the first series from the group of Minneapolis, Professor Schenk, who's still around, a psychiatrist, and he reported this first large series of 100 consecutive patients seen at the sleep lab in Wisconsin. You see young, mean age, around 30, interval to diagnosis 12 years. So this is a specialized center for parasomnias. So this was probably the most expert center in the States back in the 80s. But the interval to diagnosis, or I should say to workup, remains still very high. In some places, maybe people are not even investigated. And the sleep studies in this specific series turned out to be very helpful. in 91% it was important to come to a final decision about the cause. And the conclusion of this first study focused on injury was that half of the patients that are referred because of an injury that appeared during sleep ended up having a diagnosis of sleepwalking, somnambulism, then REM sleep behavior disorder, and much less common what you would probably think if you're not an expert, you know, psychopathology. So he's violent because he's violent during the day, or seizures. So this is actually rather the exception, that the case is not clear. So as maybe you would anticipate, most cases are related to parasomnias. Let's now have a look at a more recent study. Next, Slidushi. Now this is now specifically on violence, and you see what do we mean by violence? We mean sex assault, what has been coined as term sexsomnia. So people, usually men, rarely women, that assault the partner sexually during sleep. Homicide, 16%. I should mention that there are also cases of pseudo-homicide, attempted homicide, or attempted suicide. I have now a case of a young man of a family of sleepwalkers who was found hang up in his garage, and the question of the father, who's completely overwhelmed by this loss of his son, is whether this son killed himself because of suicide or because of parasomnia. You can imagine that for a family it's possibly more acceptable to say it was because of parasomnia than because of suicide, because you feel less guilty if it's parasomnia or whatever. And then the third main reason, it's not 100%, you see, was driving under influence of sleep or whatever happened in sleep. Now you see the numbers. This is a single center consecutive patient series of 350. You see the big difference. We're talking about hundreds of patients seen by a single center. We're talking again of Minneapolis, so this is a specialized center. And what is interesting is that if you look at the sleep-related causes, I mean, first of all, I should say that at the end, only 50% of violence appeared during sleep was related to a sleep-related problem, which is kind of an interesting information. So if you see somebody that is referred to you because of a sleep-related violence or injury, you should always think that something else could be also in place, including the fact that somebody may say he's in sleep but he's actually awake. But if you look at the sleep-related cause, it turned out that non-REM parasomnias, the use of hypnotics, and sleep deprivation were considered to be the most common cause, whereas REM sleep behavior disorder and epilepsy was quite rare. So a little bit of difference in the conclusions. Next one. Slidush. So what is the main cause? Well, I showed this nice picture of Daumier to say that sleepwalking is certainly the first association you always have to have if you see a case of sleep injury and sleep violence. But sleepwalking is by far not the only cause. So let's see what one should consider. Next, solution. Okay, now look at this patient. So this is a recording done by my friend Lino Nobili in Milano. It's a very dramatic case. And I would like to ask you at the end what you think this patient has. So by the way, you see it's a good recommendation not to interact with patients when they have spells. She's trying to calm him down, but maybe you should keep first safe. It's a short spell, few seconds, I should say 10-20 seconds, not minutes, but not a couple seconds, and the episode is over, he has no recall. So you can imagine that there is even longer interaction, some injury could appear. The beginning was very agitated, you could say even violent. So what do you think this is? Is it sleepwalking? Is it REM sleep behavior disorder? Who said no? This is not sleepwalking. What is this? This is a case of sleep wandering. This is a nocturnal epilepsy, sleep-associated epilepsy, and I will come back to the criteria and to make the diagnosis. So you see, the phenomenology is not sufficient. You need to have more information. So the history can be misleading. The history would be, he gets up, he walks around, he beats me, he shouts, but the concert of elements in the diagnostic workup of this patient led to the diagnosis of epilepsy. Let's come to the next slide, Sledushi. So these are the causes, and we wrote a couple years ago a nice, I believe, overview in the brain with some other colleagues and experts, and we had this also interesting paper in Scientific American. So what you should consider if you have the history of sleep violence and sleep injury is sleepwalking. This is cause number one. 1 out of 2 causes are related to sleepwalking. REM sleep behavior disorder can be involved, maybe less commonly than usually presumed. Why? Because during REM sleep, the motor activity is not finalistic, it's more a phasic activity, so it's rare that you build up into a coordinated, semi-coordinated action. Sleep-related hyperkinetic epilepsies, this is a new term for nocturnal frontal lobe epilepsy, as we used to say before. This is a very important differential diagnosis. When my resident tell me he must have sleepwalking, I said yes, but are you sure he does not have sleep-related epilepsy? Then you can have psychiatric problems, Münchhausen syndrome and conversion. This is not my specialty, but we do have patients that end up having a non-sleep but a psychiatric diagnosis. And then you have maybe half of the case that you see because of sleep violence are related to drugs or hypnotics. So in the series from Minneapolis, they excluded in these 351 the cases because of alcohol and drugs, and this is obviously a percentage that is increasing. And you know that some patients may develop a very weird and violent behavior following a paradox reaction to hypnotics. And then finally, malingery. People that kill somebody and then say they had done it during sleepwalking or during some other episode. So you must be aware that some patient try to fool you or the lawyers saying that they had this in sleepwalking. You know that in Switzerland, if you are a sleepwalker, you cannot serve the army. So it's, when you have to recruit young males, some of them say, well, I sleepwalk. And then they say, well, now you are free from serving the army, but you should ask a couple questions more. So the next one. So let's say just very quickly the causes. So sleepwalking is a very strongly genetically predetermined condition. You see the typical family history with a bunch of other parasomnias associated. It is not exceptional in adults. There are good studies showing that up to 2 to 4% of adults do present sleepwalking. As I mentioned, very often familiar. Next one. Seduction. Now, this is not something that recur many times per night, usually 1, 2, exceptionally 3, 4, is, as you know, a pathology of the deep phase of sleep, so it's typically in the first part of the night. Abrupt awakening, deambulation, no dreams, and amnesia. This is a typical feature. I will come a little bit later to a very important point about sleepwalking in adults, where this typical profile is not always seen. So absent of dreams and absent of recall is not mandatory in adult sleepwalkers. Next one. You can have idiopathic or post-lesional. Next one, and the treatment, sledushi. You may have a video that can help, and you must think about epilepsy or overlap parasomnia in differential diagnosis. Next one, sledushi. Okay, now you see the variety of presentation of sleepwalking. Look down the right, this is a guy who is violent during sleepwalking. You see how he's done with the fist, so he's ready to hit. The first one was a famous case because we actually did a SPECT recording, and look up on the right now. Oh, it's not working. Can you push on the... I'm not sure why the first one is not.
Нажмите на экран, пожалуйста.
Да.
Мышка.
Сейчас, да. Обратно, пожалуйста, потому что он не знает почему.
Обратно сначала.
So this is a familiar case, the first on the right, but unfortunately you did not see the beginning. It has a very paroxystic element, so it's very abrupt. So it's not easy in each single case to differentiate from epilepsy. The beginning can look very much like epilepsy, and there are more circumstantial other elements that may help. And нажимайте здесь, пожалуйста, налево, внизу, налево, пожалуйста. Не знаю, почему не работает, но...
Левый нижний экран не работает?
This is a home video. This is you see the patient walking around in his room. So he has a video. He's hitting with his legs against the table where the video is placed. So this is a very severe, very violent sleepwalker, familial, and we asked him to make recordings at night. And you see he sees the video camera and he's looking for the video camera. So this is not very informative as a video, but it shows you that you can demonstrate the confusional state of the patient who is attracted by the light but cannot identify it, and by the fact that the episodes in sleepwalking are longer than in... Look now on the upright. Look on the upright. At the beginning. Okay, следующий. So you see, by history is not always easy. Now, this is a series from Bern showing that some patients with sleepwalking end up in the emergency room. It's not common. And they can have, very severe injuries, paraplegia below thoracic vertebra, shoulder luxation, upper back contusion, minor head injury, intra-articular distal radius fracture, contusion of the ribs, thoracic hematoma, multiple contused facial. So sleepwalking can be a cause of severe injury, leading patients to the emergency room. Not common in our experience. The next one, следующий. Now this is a small series we just published, showing the similarity between adult onset and childhood onset sleepwalking. As you know, some patients with sleepwalking may start having sleepwalking only in adulthood. But what I would like to mention to you is that if you look here, childhood onset, 45% sleepwalking related self-injuries, violent behavior 44%, sleepwalking related self-injury 33% in adult sleepwalking, adult onset, and 29% violent behavior. So it is frequent, but not always very dramatic. It can be an injury, an hematoma, and so on and so forth. Now what we have found in this series is also that adult sleepwalkers, not the childhood type sleepwalker, but the adult onset sleepwalker may have a recall of what happened. So the amnesia is not always complete, point one. Point two, sometimes they may recall some oniric experiences. They may remember something. So the idea that sleepwalking is always accompanied by amnesia or by absence of any mentation is wrong in adults, which makes it a little bit difficult then to differentiate from REM sleep behavior disorder. And this is why some patients with adulthood sleepwalking and violence sometimes are referred for having REM sleep behavior disorder, despite the fact that they end up having sleepwalking, or a combination of the two, which is called overlap parasomnia. The next one, следующий. Now REM sleep behavior disorder, next one, следующий, is obviously a rare condition. This is not 1-2 spells, it's multiple spells per night. Sometimes there are showers of spells that come. It's typically the second part of the night. So this is a dog who probably has a deficient REM matonia. And this is what happens, they act out their dreams, our patients, and they have also a change in the mentation. So I would like to stress the fact that it's not just the loss of muscle atonia, as everybody says. There is an activation of something, because also the contents of dreams is altered and is actually exaggerated. Следующий. As you know, idiopathic or secondary, I will not go into very much details. You know that you can see secondary RBD in the context of neurodegenerative diseases. brainstem lesions, and some autoimmune disorders. And the diagnosis requests video PSG. I would like to tell you that you should not rely only on the history. The history can be misleading. And the treatment is usually clonazepam. Next slide. This is a typical case, not spectacular. Very often elderly males. And the history is that of excessive jerking, sometimes with hitting, shouting, crying, gesticulating, and what you need to show is that during REM sleep, you have an excess in phasic and tonic muscle activity. So this is a diagnosis that you must suspect by history, but the specificity of the history is maybe 70–80%. So it's not 100. You can have a typical REM sleep behavioral disorder history and you end up having a non-REM parasomnia. And this is, you see that he's hitting himself. This is not as violent. It's quite interesting because if you look at European videos about RBD and North American videos about RBD, the degree of violence is higher in the North American videos. We may discuss what the explanation could be. The next one, следующий. Now, there is a very interesting psychological moment in this condition that, this is the same person, this is a couple, and, this guy who was very friendly, he's with his wife during honeymoon, he remained very pleasant, but he had to, secure himself with this belt at night to make sure that he does not fall out of the bed and injure himself, and he ended up sleeping by himself. So how do we explain this Dr. Jekyll, Mr. Hyde phenomenon that you see in RBD? This is still unsolved. Next one. In other words, how this very nice gentleman during the day becomes such a violent person during the night. So it's about the violence and brain regulation in sleep. And this is an interesting topic we may discuss later. Next one, следующий. Now you see that idiopathic RBD is a predictor of dementia and Parkinson's disease, so it's a very important clinical diagnosis. Next one. следующий. And as you know, the beginning is in the gut, probably, or at least in other organs, because you can find signs of synuclein deposits, the hallmarks of this pathology of Parkinsonism and synucleinopathies in the gut or even in the skin. So this is a very interesting topic about the interaction between the external world, the gut, and the brain, and I know that Professor Picarev and others is very interested in these links. следующий. Now the third pathology that we should know is sleep-related hypermotor epilepsy. This is a disease that is typically confused with with parasomnias. This is a famous first report of this condition. Abnormal autosomal dominant epilepsy, misdiagnosed as sleep disorder. So please consider it always in the differential diagnosis of nocturnal episodes also epilepsy, although usually it's not epilepsy, but it can be epilepsy. It's very rare, occasionally familiar. Next one. следующий. Multiple spells, very short, and abrupt, stereotyped, and hyperkinetic. Stereotyped, it means always the same evolution of the episodes, and hyperkinetic means lots of motor activity. So it's a little bit like RBD and sleepwalking, but again, multiple spells, and not specifically in the first or in the second part of the night. Next. It's not called anymore nocturnal frontal lobe epilepsy because the origin of this epilepsy can be also temporal and occipital. So it's not a frontal lobe disease, it's just a disease of epilepsy control at night. Next one. Usually you find a cortical dysplasia, and the diagnosis is the video PSG. Now I would like to mention, however, that the EEG can be normal in 50% of cases. You know that with the EEG you can record only 1/6 of the entire cortex, so it is not surprising that depending where is the focus in the cortex, the EEG, the conventional EEG, is not able to depict and to find the origin of the epilepsy. So this is an epilepsy that you can diagnose and must diagnose also in the absence of EEG epileptiform activities. So So this is important because the good epileptologists know that the EEG is very important, but it's not everything in epilepsy diagnosis. This is a good case. And the therapy is antiepileptics, and sometimes you can use epilepsy surgery if you can find the origin of this condition. Next one. Depending on where in the frontal lobe, but it's not only the frontal lobe, the phenomenology can differ. So the phenotypic presentation of this epilepsy may be quite variable, so maybe somewhat a challenge. Следующий. And you see now 3 different patients. Sometimes patients have this snake-like movement. Some patients, like this one, have very stereotyped. These are 2 different episodes in the same night. You know, it's almost the same sequence of events. Very stereotypical, as we say. This person was convinced of having parasomnia. He came from London to me, hoping that I would say, no, you don't have epilepsy, you can drive the car. And actually I told him, I'm sorry, but I think you have epilepsy, even if it's only at night. And he had this kind of gorilla-like behavior, you know? So you have different patterns, and probably depends on where the origin starts, and typically they are repetitive and stereotypic in their presentation. So quite variable phenotypical presentation. And what I want to leave you with all these videos is the importance of the video. So it's not just the EEG, it's not just the history. You need to have a video, and if possible, more than 1 video of episodes. Next one. Now, if you want to make the diagnosis of sleep-related hypermotor epilepsy, we had this consortium. You need to record not only polysomnography but also EEG. Next one. Now, how do you approach this problem? Sleep violence, sleep injury. Next one. History, video PSG with EEG, if you can. If you are not able to depict a single episode, you know, episodes do not come every night, so you must ask the patient, as I showed you one example, to get home video recordings, the husband, the wife, the relatives. Psychiatric evaluation may be important, and the problem of forensic evaluation is that it's basically always retrospective. So if you have a homicide, suicide, or very severe sex assault during the night, you have to do a mosaic work of putting together different elements and trying to solve what the cause could be. And this is a very nice list of elements that you may want, and actually you need to collect when you have to judge on a potential forensic case, or if you have to do a forensic evaluation. Presence of an underlying sleep disorder, characteristic of the acts, abrupt onset, impulsive, senseless, lack of awareness. The victim, where is the victim? Is in the place just by chance, coincidentally, or not? On return of consciousness, what is the behavior of the patient after waking up? Does he try to leave the room? Does he try to confuse the scene? Or is it perplexed? Is it his horror of what happens? Or try to escape? Presence of precipitating factor and so on. So it is a mosaic, and some experts say you never have the final certainty about the case. But you can balance probability and say, well, we believe it could be related to this or to that. Next one, следующий. So let me show you now the workup of the 2 patients, and we come to an end of the talk. So this is the case. What was the history of this patient? When there was a history, a personal history of enuresis and sleepwalking, clear history, confirmed by the family. The patient was having stress because of financial problems, and he was actually recently fired from work, but he had a very good relationship with his parents-in-law, so there was no litigation with them. And there was also a family history of sleepwalking, enuresis, and sleep talking, so a very, I would say, typical context. So what the workup showed up, neurologic exam, EEG, brain CT normal, at that time was brain EEG. The video PSG showed a quite typical finding, although, as you know, there is nothing specific in the polysomnography about sleepwalking, unfortunately, so we cannot say you have sleepwalking or not just on the video PSG, but he had state shifts, he had a hypersynchronous delta, and has somewhat elevated slow wave sleep. So typical finding. And then the psychiatric workup showed that he had depression and anxiety, but he was very remorseful. There was no doubts about the fact that this was a shock for him and for the family. There was nothing that could be found in terms of aggressivity or any motivation concerning this killing. So the verdict at the end was that he probably did this during a sleepwalking episode. Next one. What's about the second patient? Well, what was the history of this patient? She is a good sleeper with only tension headache. She had a bypass surgery because she was much larger. She lost 30 kilos. So there was some psychiatric, psychological sufferance. She actually developed after the bypass surgery for a short period of time restless legs, and she had 2 confusional arousal after taking zolpidem. She had a very problematic marriage, and the family history was positive for depression and alcoholism, 2 brothers with aneurysms, and 1 daughter with sleepwalking. Now, what was very shocking was to happen to know that the first daughter of this woman was died of a sudden infant death syndrome. So there was already a dramatic history in this family. What was then important was the workup, which was actually negative for neurological findings. The EEG was normal, the brain MRI. She had 2 video PSG, 1 spontaneous that was compatible with sleepwalking, but not specific, with some hypersynchronous delta. And then she said, well, there was one element of the history is that she said she was having sleepwalking as a child, and when we contacted her parents, they denied the fact that she had sleepwalking. I did not write it. But then we asked her to take a zolpidem, although that night she did not take zolpidem because she said, I had these 2 confusional episodes. And when she took this zolpidem, and I cannot show you the video, she had an episode of what she thought was sleepwalking. She had a robot-like behavior. She moved around like this. So this was very suspicious for us. Next one, Sledushi. So you see how you should work up, and it's never, unfortunately, black and white. So if you look at the left patient, he had a positive family history, he had a personal history, he had anxiety, he had the onset after the first hour of sleep, senseless action. One could argue about driving, but was mentioned to be rather senseless, and he was very remorseful. What's about the first patient? The family history was positive to some extent, but there was also this sudden infant death syndrome, which was peculiar. The personal history for sleepwalking was negative. She was anxious, and what I should explain is that the 2 children slept in 2 different rooms. So she entered the first room and she entered the second room. And during the whole psychiatric workup, she was very mistrustful. So she did not show any remorse, and she was very peculiar in her appearance. Let's come to the conclusion of the 2 cases. Sledushi. And please pardon me, obviously we do not judge these things in 5 minutes, so there was a much longer consideration. I just show you how we approach this. It's not that I can solve a case like this and decide about possible culpability or not in 5 minutes. It's just for didactic reasons that I present it in such a short way. Next slide, Sledushi. So what happened? So in the first case, this is the famous case published by Roger Broughton. This was considered to be homicidal somnambulism. So the final judgment of the first patient is that this happened during a sleepwalking episode. So the patient was considered non-guilty. Now the second patient was a kind of a thriller story because we were not allowed to talk to the psychiatrist during our expertise. So this is the beginning of our Gutachten, of our expertise, and at the end, and I did it with Dr. Sickler, we said, we believe this was not a parasomnia or epilepsy related, but we should know more about the patient, and we leave it to you. The psychiatric workup that we received after we submitted our expertise was full of contradictions, including unprecise history and then the mistrust of the patient. But then what happened is that during the forensic debate, the patient eventually confessed of having killed both children as well as the first one. Next slide. So this is what she then declared. Пожалуйста, обратно. So this is the article that appeared few months after the first forensic debate, where she said, "Das bin ich meinen Kindern schuldig. I must say this for the 3 children that I killed. I killed them." So this is a very dramatic story. But the good thing about the workup is that we said that we believe it's not a black and white decision, that this was not a sleepwalking or a REM sleep behavior or an epilepsy-related sleep violent episode. Let me come to the last slide. So what can you do? Well, it depends on the diagnosis. Is it clonazepam for sleepwalking? Is it melatonin or clonazepam for RBD? Antiepileptics, epilepsy surgery, and then you should have prevention. I'm sorry, I did not translate. Schutzmaßnahmen, so do something in the environment to protect the patient's psychological support and follow-ups. Следующий and последний. So I tried to show you that this exists, is not just a fairy tale. So we do have cases of sleep injury and sleep violence, up to the very extreme cases of homicide, suicide, and severe injuries. In the cause, it's not only sleepwalking, it can be REM sleep parasomnia, it can be epilepsy, it can be the influence of alcohol and drugs, it can be malingering, somebody's lying to you. And the management is a composition of different elements. It's not just a history, it's not just a video, it's not just a sleep EEG, and this is usually a multifactorial and multidisciplinary approach, particularly if the case becomes a forensic case. Thank you very much.
Вопросы? Пожалуйста. Еще раз. Громче.